Hey guys, welcome back to my channel. Today we'll be starting with the rapid revision of gynecology. Let's begin. Let us start with the development of gonads, which takes place at 5 weeks. The differentiation between male and female occurs due to the presence of SRY gene at the distal end of short arm of Y chromosome at 7 weeks. So, due to the presence of Y chromosome, the Leydig cells they secrete testosterone, which leads to the formation of Wolffian duct by the end of 8 weeks. And testosterone also gives rise to the male external genitalia. Whereas the Sertoli cells, they secrete Mullerian inhibiting substance, which promotes the regression of Mullerian duct or inhibits the formation of Mullerian duct. Right. So these two things occurs due to the presence of Y chromosome and the SRY gene. Now, uh, the Y chromosome, we know that it stimulates the formation of testes in males, and the absence of Y chromosomes leads to the formation of ovaries in females. But the functioning of ovaries is determined by the presence of X chromosome, and that too there should be two X chromosome. For example, in Turner's syndrome, there is the karyotype of 45XO, or the absence of one X chromosome, that leads to the formation of streak gonads, right, or the non-functioning ovaries. Since there is absence of Y chromosomes, the ovaries will be present, but there will be streak gonads or non-functioning ovaries. Alright, Turner syndrome is very important. Then, uh, talking ahead, let us start with the development of internal genitalia. Right. So, starting with the development of internal genitalia in female, it comprises of fallopian tube, uterus, and vagina. Remember, very importantly, that it is the upper one third of the vagina that is formed by the Mullerian duct. The lower two third is formed by the urogenital sinus, which we will read in embryology. Now, what happens is that since there are no Sertoli cells in the females, so MIH will not be secreted, and therefore Mullerian duct is formed, giving rise to the female internal genitalia, like the fallopian tube, uterus, and the upper one third of the vagina. Now, the absence of Y chromosome um, and the absence of testes, right, they lead to the formation of Mullerian duct. We've already discussed this because there is no Mullerian inhibiting substance, as in males it was being secreted by the Sertoli cells. Yeah, let us write lower one third, I'm really sorry, lower two third of the vagina is formed by the urogenital sinus, and remember that it is an endodermal derivative, while the upper one third is a mesodermal derivative because it derives from Mullerian duct. Also, vaginal epithelium, it is formed by the endoderm of urogenital sinus, and it is a very important question. Therefore, it will also be endodermal in origin, obviously, because it is formed by the endoderm of the urogenital sinus. Right. The estrogen, it is responsible for the growth of organs at puberty. Now, this is very important, right? Remember, if there is absence of estrogen, it leads to infantile or hypoplastic uterus, like we saw in Turner's. Like, right, there were streak gonads or streak ovaries. Why that was happening? That was because of the absence of estrogen. Now, here, let us discuss the uterine malformations. So, A female presenting with uterine malformation would come with a history of recurrent abortion, right? Then we will advise her to undergo ultrasound because that is the first investigation that is done, and we prefer a transvaginal scan over a transabdominal scan as it delineates the anatomy of uterus better. Also, if the question is asked, then the first investigation is HSG, histosalpingography, or a TVS. Any of the option is correct. More commonly in the practice, we see that on ultrasound, the Mullerian malformations are detected. Then on HSG, any Mullerian malformation that distorts the cavity can be seen, right? We cannot see the outer contour or the external appearance of the uterus or the uterine fundus on HSG. We can only visualize the uterine cavity. Talking about the investigation of choice, it is 3D ultrasound and the gold standard is MRI. This question regarding the investigation is very important. The first investigation, investigation of choice, and gold standard. Most common uterine malformation, it is septate followed by bicornuate. For septate, we do hysteroscopic resection of the septa, and for bicornuate, we perform Strassman's metroplasty. This is a unification surgery, right? Now, what will be the chief complaint of the female? We've already discussed recurrent abortion, indication for surgery, right? Then do ultrasound KUB to rule out renal anomalies, either USG KUB or X-ray KUB, right? Or pylography basically. Classification. Class 1 is Mullerian agenesis. The female will have complaints of amenorrhea. Then class 2 is unicornuate uterus. So on HSG, we will see a single fallopian tube and a single uterine cavity. Okay, one side of the Mullerian duct is absent here, and the one side that is present will give rise to the cornua. Then HSG picture will show one fallopian tube, half uterus and cervix, and half vagina. Right. Also, in some cases, there can be a single uterine cavity with a small rudimentary horn. Rudimentary horn. Right. So this is class 2 unicornuate uterus. Now the clinical features, there will be unilateral dysmenorrhea. This is very important, right? Because only one side of the uterus is present. This is associated with ectopic pregnancy and ectopic ovary. Also, there is renal anomaly like unicornuate uterine malformation is the most common uterine malformation that is associated with renal anomalies, and that is why we also perform KUB. Coming to class 3, Now, there is failure of Mullerian duct to fuse in entire length. Caudal to cranial, and there will be presence of two fallopian tubes, two uterus, two cervix, and the vagina can be either a single vagina or two vagina, or we can also have a vaginal septum. Alright, so based upon vagina, we do not call it a diadelphys uterus. It is diagnosed on the basis of cervix, and this is called diadelphys uterine malformation. Right, very important point. There are two cervix here. Now on HSG, we can also see two HSG cannula because to visualize the uterine cavities. And when is HSG done? It is done on day 7 to day 10. And the contraindications for histosalpingography are active infections like PID and active genital TB. Alright, so here we have three classes: class 1, class 2 and class 3 uterine malformations. Class 4 and class 5 are biconvate and septate uterus. Class 6 is arcuate, and class 7 is due to diethyl silvestrol use. So we're done with female internal genitalia. The male internal genitalia is formed by the Wolffian duct, which includes seminiferous tubules, epididymis, the ductus deferens, and the ejaculatory duct. Then the remnant of mesonephric duct in males are appendix of testes, not the epididymis. Remember, this is very important. The appendix of testes is a remnant of Mullerian duct as well as prostatic utricle, while appendix of epididymis is derived from the Wolffian duct. Alright, then the Wolffian duct remnants in females will be the epoophoron and the paraoophoron. Epoophoron from cranial tubule, paraoophoron from the caudal tubule, very important. And Gartner's duct, which is formed by the caudal mesonephric duct. Right. So epo and para are formed by mesonephric tubules and Gartner's duct by the mesonephric duct. And the epoophoron lies in the medial part of the broad ligament, while the paraoophoron lies in the lateral part of the broad ligament. This completes the internal development. Now the development of external genitalia. Right. So in males and females, let us see the homologous organs, penis and clitoris, which are derivatives of tubules. Scrotum and labia majora are the derivatives of genital swelling. Then urethra and the labia minora are derivatives of the genital folds. Then the homologous of prostate in females are gland of Skene or the paraurethral glands, while the Copper's glands or the bulbourethral gland corresponds to the Bartholin's gland in female, also known as the greater vestibular glands. Right, this is very important. Remember, Cowper's is homologous to Bartholin's and prostate is homologous to paraurethral gland or the gland of Skene's. Right. Alright, now moving ahead, The Leydig cells secrete testosterone, which is converted by 5 alpha reductase enzyme to dihydrotestosterone, which is responsible for the development of male external genitalia. Alright. Now, the absence of testosterone in females, it gives rise to the formation of female external genitalia, right? Because testosterone cannot be converted to dihydrotestosterone. So the absence of testosterone or dihydrotestosterone in females gives rise to the female external genitalia. Now the external genitalia is differentiated by 12 weeks, while the internal genitalia differentiates by 10 weeks. Okay, so when can sex differentiation be made on ultrasound is the question. So the gonads, the internal and the external genitalia, right? They differentiate by 7 week, 10 week and 12 weeks respectively, and therefore external genitalia is seen on ultrasound. So by ultrasound we can determine the sex by minimum 12 weeks. Now let us talk about the abnormal disorders of sexual development or the abnormal development. This is a very important topic, right? And the older terminologies that were used for DSD are pseudo-hermaphrodite. It can be male, which has a karyotype of 46XY. So testes will be formed, right? But the external genitalia would be that of a female. So this happens due to either absence of testosterone, deficiency of 5 alpha reductase enzyme, because testosterone will not be converted to dihydrotestosterone, which is responsible for the formation of the external genitalia of male. Hence the genitalia will be female external genitalia, right? Or they can be receptor insensitivity. That is, the testosterone receptors are not sensitive to it. So testosterone will be produced, dihydrotestosterone will be produced, but there is receptor insensitivity, and this is called androgen insensitivity syndrome and is the most common cause of male pseudohermaphrodite. Talking about female, again the karyotype will be 46XX, but the external genitalia will resemble that of male due to uh, increased androgenic exposure in the intrauterine life. Right. This causes clitoromegaly, the enlargement of clitoris, and the fusion of labia majora. So it appears like a scrotum. These changes are called as virilization, very important, and this is due to congenital adrenal hyperplasia, and the most common cause is deficiency of 21 alpha hydroxylase. Right. So in males, pseudohermaphrodite, there is the most common cause of androgen insensitivity, while female pseudohermaphrodite, the most common cause is congenital adrenal hyperplasia. So talking about CAH, what are the enzyme deficiency, right? So What happens is basically that there is increased androgens due to 21 alpha hydroxylase deficiency. Also, there can be deficiency of 11 beta hydroxylase. In males, there can be androgen deficiency that leads to pseudo hermaphrodite, and 21 hydroxylase causing increased androgen leads to female pseudo hermaphrodite. The male pseudo hermaphrodite is due to 7 beta HST or 7 alpha hydroxylase deficiency, leading to decrease in androgen production. Now, both male and female pseudohermaphrodite can be caused due to deficiency of 3 beta HSG. Right. So, female is due to 21 alpha hydroxylase, male is due to 7 beta HSD, and male or female both or either of the two can be due to 3 beta HSD. Right. That are the main deficiencies in CH. Coming to true pseudohermaphrodite, or also called as ovotestes. That is, like one side will have fully functional ovaries and the other side will have testes. The most common karyotype is 46XX, and rarely we can see 46XY or mosaicism. Right? Now, what is ambiguous external genitalia? So, clitoromegaly or labial fusion in females and micropenis or hypospadias in males is ambiguous external genitalia. Like, we cannot make out, depending upon the external appearance, whether the baby is a male or a female baby. The most common cause in males is androgen insensitivity syndrome, and the most common cause in females is congenital adrenal hyperplasia. Now, what is the next step if you see a baby with ambiguous external genitalia, which is a very important question, right? So the next step would be to do a physical examination, right? What we do is we see whether the testes are palpable or not. If the testes are palpable, then it is a male, it is a case of male pseudohermaphrodite, right? And they also ask what is the best step. So the best step or the best investigation is karyotype. These two questions are very important and they are asked in any kind of exam. Now, let us look at the differential diagnosis of DSD with 46XX karyotype. First is 21 alpha hydroxylase deficiency, right? We've already seen it is the most common cause of female pseudohermaphroditism. Then there will be mineralocorticoid deficiency, right, causing salt wasting and low BP, and it is a life-threatening condition and needs to be managed. Second is 11 beta hydroxylase deficiency, and third can be ovotestes because we saw that the most common karyotype was 46XX. Finally, 3 beta HSD can also lead to 46XX. DD of 46XY or male pseudohermaphrodite, most common is AIS, right? There can be clitoromegaly, then it is called partial AIS. Remember, very important. Second is 5 alpha reductase deficiency, and third cause is congenital adrenal hyperplasia, right? Which deficiency? 17 beta hydroxylase deficiency, and also finally 3 beta HSD, which can lead to either female or male. This table is very important and you should write it down yourself and remember it by heart. So, infertility is defined as inability to conceive for more than 12 months in a young female who's less than 35 years of age, or more than 6 months in a female who is more than 35 years of age. Why is it done? Because these females have decreased fertility due to increase in age, right? Now, infertility can be either female factor infertility, male factor infertility, or those due to unexplained causes. In female factor infertility, it is further subdivided, but the most common cause is anovulation. Okay, anovulation is a type of ovarian factor infertility in female, and ovarian factor infertility is the most common cause, followed by tubal causes of infertility. Now, there can be premature ovarian failure, gonadal dysgenesis, increased in prolactin due to a pituitary microadenoma, but the most common cause of ovarian infertility remains anovulation. So we do tests for ovulation to find out whether the female has ovulated or not. So if a female has regular cycles, that is an indirect indication that the female is ovulating. All right, and anovulating females will complain of anovulatory cycles with anovulatory bleed, that is, no corpus luteum is formed, so there will be no progesterone. Now, due to the absence of corpus luteum, there will be weak endometrium. All right, so under the influence of estrogen, the endometrium will proliferate, but it is weak due to the absence of progesterone, and there will be estrogen breakthrough bleed, which is painless, heavy bleeding, right? So, regular cycles with pain is an indirect indication of ovulation. Pain occurs due to PGF2 alpha, which is released due to the constricting action on the spiral arterioles. While the indirect sign of anovulation will be heavy, painless, breakthrough bleeding due to the effect of estrogen. Now let us see at the test for ovulation. The first one is serum progesterone. Right, so it is done on day 21 to 222 because at that time serum progesterone is the highest and it should be more than 3 nanogram. This indicates that ovulation has happened. So when should it be done? Day 22-21 means 1 week before the menses. Second test is cervical mucus. So it is also known as Spin-Barkett method. The cervical mucus would be thin, watery, copious, and the electron microscopy will show ferning in the first phase of the cycle, that is the follicular phase, or under the effect of estrogen. Right. Also, it's not just estrogen, it's estrogen plus sodium chloride because estrogen is responsible for salt and water retention. Under the effect of progesterone, there will be loss of ferning. This is best seen on day 18. The mucus will be thick and easy to break, while under the effect of estrogen it is stringy and it does not break easily and stretches. That shows anovulation, while loss of earning shows that ovulation has taken place. The third test is upper one third lateral wall of vagina sampling. Right. So, under the effect of estrogen, there will be a predominance of superficial cells. How are these cells? They are pink in color, eosinophilic, with a small pycnotic nucleus. Under the effect of progesterone, the intermediate cells will be seen. They are basophilic and the nucleus will be slightly larger in size. If there is no hormonal influence, there will be presence of parabasal cells. Here, the cell will be having a large nucleus with blurred margins, right? So these type of cells are seen either in a prepubertal female or in a postmenopausal female. No ovulation is seen with estrogen, while ovulation is seen with progesterone. Now, coming to the fourth test, which is biopsy. Again, under the effect of estrogen, we'll see simple tubular glands. Also, remember that in ovulation, when ovulation occurs, there is presence of subnuclear vacuoles. Let me draw it. So, these are the nucleus, and below the nucleus, we will see clear spaces, right? So, these are subnuclear vacuoles. They are seen in early follicular, I'm so sorry, they are seen in early secretory or late proliferative phase. All right, that is right for progesterone. They will have tortuous glands that are also called as corkscrew gland, or they're also known as sawtooth appearance of glands, signifying late secretory phase. Now, on day 22, the presence of corkscrew glands will indicate that ovulation has occurred. Fifth test is prediction of time. It can be done by TVS by monitoring the size of the follicles. It is done on day 10 of the cycle, and there is increase in the size of follicles by 2 mm per day till it reaches 18 to 20 mm in size, which is the size of a mature follicle. Decrease in size of the follicle with fluid in the pouch of Douglas and a tri-lamellated endometrium signifies that the follicle has ruptured or ovulation has occurred. So there will be decrease in size. Why would there be fluid? Because the antral cavity has fluid in it, and the rupture of follicle would lead to release of this fluid. Now, when we perform a TVS, the trilamellar endometrium would appear like this. Right, there are three layers in the endometrium. This signifies that ovulation has occurred and we are seeing the late proliferative phase. While if the uterus shows a thick endometrium with posterior enhancement, right, there will be posterior enhancement. It shows that it is the late secretory phase. All right, now moving ahead, the most common cause of infertility is anovulation, that is PCOS. Right, it is the most common cause of anovulation right? And it is also the most common cause of hirsutism. So, what happens is that there is increase in androgens, which in turn is toxic to the follicles, and the follicles don't mature. Thus, increase in androgen is usually less than 200 nanograms. In obese patients, what happens is that there is increase in estrogen as well due to the peripheral conversion in adipose tissue. All right, and this is E1, that is estrione. There is alteration in E2 is to E1 ratio. Normally, the ratio is 2 is to 1, but in PCOS, it is 1 is to 2. Right, it's due to the increase in estrione. Remember that always. Right, talking about the potency, E2 followed by E1 followed by E3. E2 is the reproductive estrogen, while E1 is the estrogen predominant in menopausal female, and E3 is predominantly seen in pregnant states. Now, what happens is that there is anovulation due to follicle immaturity. This leads to decrease in progesterone, decrease in menstruation, that is oligomenorrhea or even amenorrhea. Due to the effect of increased estrogen, the endometrium is thick and there is absence of progesterone, so that will lead to breakthrough bleeding. Oligo and amenorrhea is commonly seen in thin females, while obese females will complain of heavy painless bleeding or menorrhagia. Let us talk about the Rotterdam criteria, in which more than two of the three must be present to diagnose PCOS. First is oligoamenorrhea and amenorrhea. Remember that menorrhagia is not included in the Rotterdam criteria. Second is increase in the androgen or increase in testosterone levels and increase in androgenism. Criteria is the ultrasound diagnosis of PCOS. Here we will have small numerous follicles more than 12 in number and less than 10 mm in size with within an enlarged ovary measuring more than 10 cc. Remember that we already studied that the stroma of the ovary becomes echogenic, while this arrangement is called as necklace pattern. These two are not included in the Rotterdam criteria. Now, obesity, insulin resistance, and LH-FSH ratio, these are all not included in the Rotterdam criteria. Provisional diagnosis of PCOS. Right. Why? Because late onset CAH needs to be ruled out. Right? Remember, we studied that it is a differential of PCOS, and in this condition, there will be high levels of 17 hydroxyprogesterone. To confirm it, ACH stimulation is done. Investigations for PCOS include testosterone levels, which will be increased. The normal is in the range of 70 nanogram, while here it rises to 150 nanogram. Testosterone more than 200 nanogram is suggestive of androgen secreting tumor of ovary. Then ultrasound is done because the chief complaint of the female is amenorrhea. TSH, LH, FSH, and prolactin levels are done. In PCOS, TSH and prolactin will be normal, while there will be increase in LH because the androgens gives rise to increased estrogen, and high levels of estrogen stimulate LH while they have a negative feedback on FSH. PCOS, LH is persistently high and therefore there is no ovulation occurring in PCOS. LH to FSH is generally 2 is to 1 or 3 is to 1. It is measured on day 2 or 3 of the cycle. OGTT, because the female has insulin resistance, so we measure the glucose levels. Also, dyslipidemia is present, hence lipid profile. Sex hormone binding globulin due to decreased due to insulin resistance and androgen which are high in amount. Okay, now talking about the management of PCOS. So it depends upon the presenting complaint with which the female comes, but the general management for everyone is lifestyle modification with weight loss. So if the female comes with complaints of hirsutism, we prescribe OCP, and remember the progesterone should be third or fourth generation while low dose estrogen should be used in the combination. The example of third generation progesterone is gestodine and desogestrel, while fourth generation progesterone are spironolactone derivatives like drospinone. For irregular menses, uh, we again prescribe OCP, and for insulin resistant, we give metformin. Now, if a female comes with complaints of infertility, or basically, we'll talk about the treatment of anovulation. So, 5% of females they have benefit from lifestyle modification, but those who do not, we prescribe letrozole, which is the drug of choice, more than clomiphene citrate. It is an aromatase inhibitor. Now, increase in FSH leads to increase in growth of follicles. Therefore, we add injection HCG to promote follicular growth. It is an ovulation trigger. Second line, drugs include HMG, which is a combination of LH plus FSH. Recombinant FSH can also be used, but the problem is that it is expensive. So second line drugs, they have complications like multifetal pregnancy. The risk is 30% with HMG and the risk of OHS is 5%, while with clomiphene citrate the risk of multifetal pregnancy is just 5 to 8%. Hence clomiphene citrate is preferred over HMG and FSH, and they are second line drugs for treatment of anovulation. We can also do surgery, which is the laparoscopic ovarian drilling. Right. So here what we do is that the stroma is burnt. Now what will this do? That LH is secreted from the theca cells, which stimulates the androgens. But due to this burnt stroma, this will not take place. So the side effects for this can be, if there is too much of burning, it will lead to ovarian failure, right, and cause premature menopause. So surgery is always less preferred as compared to medications. Now letrozole, it is a drug of choice for anovulation due to PCOS, while clomiphene citrate is the drug of choice for anovulation overall. Talking about second cause of anovulation, it is premature ovarian failure, right? So ovarian reserve is measured by serum FSH. If it is less than 10, then it means it is a good reserve. Between 10 to 15 is borderline, while more than 15 indicates a poor reserve, and more than 20 is suggestive of ovarian failure. Now it is measured on day 3 of the cycle. What happens is in anovulation, due to decrease in estrogen, there is loss of the negative feedback on FSH, and therefore it increases. First is serum FSH, second is AMH, and it is the best test to measure ovarian reserve. Right? It can be done on any day of the cycle. So, a decrease in follicle would cause decrease in serum AMH, and a value less than 0.5 indicates a poor reserve, while less than 1 would indicate baseline value. How to treat? We have to do IVF with donor eggs. Now let us move ahead to tubal factors. So the investigation of choice to test the patency of tubes is HSG, which is histosalpingography. It is done in the first half of the cycle, preferably day 10, and Leach-Wilkinson cannula is used. It is a funnel-shaped cannula. Right. It is inserted in the cervix, and a water-soluble iodinated dye is passed through the cannula. So what picture we will get? We will see opacification of endometrium, fallopian tubes, followed by a free peritoneal spill. So presence of bilateral spill is indicative of tubal patency. What are the limitations? That the outer part of the fallopian tube is not visualized, right? The external appearance. So for that, the gold standard is laparoscopic chromopertubation. Here what we do is that we do laparoscopy and visualize the fallopian tube with our own eyes. So the external contour and external appearance can also be seen. The contraindications are pregnancy, any active PID or TB, and active bleeding. How to treat? We just treat bilateral tubal block. Unilateral tubal block need not be treated. So it is divided into proximal or cornual block and distal or fimbrial block. Right. So suppose this is the uterus that is opacified. We will not see any fallopian tube. The most common cause of cornual block is physiological. Right. It occurs due to cornual spasm due to the passage of dye. The cornua undergoes spasm. Then genital TB is the most common pathological cause of proximal tubal block. How will we confirm? By doing the gold standard again. We pass a guide wire, right? We are doing a laparoscopic chromoperturbation, and we pass a guide wire, and we also do hysteroscopic cannulation that relieves the spasm. If the spasm is relieved, then it indicates a physiological cause. Right. So, laparoscopic chromoperturbation with hysteroscopic cannulation will be the next step if we see proximal block. While the best management would be IVF. This is very important. Next management and best management. Now coming to the distal block. So here we can see dilated fallopian tubes without any spill. This is known as hydrosalpinx. Right, पानी भर जाता है tubes में. Okay, and the distal block basically can be classified without hydrosalpinx. This is a mild disease, while the treatment will be laparoscopy followed by fimbrioplasty and adhesiolysis. Right. If hydrosalpinx is present, then it is a severe disease, and the treatment would include IVF. Let us talk about genital TB. Right, it is due to spread from primary site like lungs followed by lymph node, and it is a hematogenous spread. All the PIDs, they are spread sexually, and TB, genital TB, is one PID which is not spread sexually, and it is the most common cause of PID in virgins. Most common site is the fallopian tube, in which ampulla is the most common part, followed by isthmus. Uterus is the second most common organ involved, and the least common site is vagina and vulva. On HSD is contraindicated, but if it is done, then what will be the things that we see on HSG which can be asked as a direct question in the exam? So the first sign is tobacco pouch appearance, beaded appearance or string on bead appearance, lead pipe appearance, golf stick appearance, cotton wool appearance, sorry, and cobblestone appearance. Right. Then there can be presence of bilateral hydrosalpinx as well, or it can present with adhesions, which is called frozen pelvis. Uterine TB is spread by direct spread from the fallopian tubes. It is not spread hematogenously like fallopian tubes. Remember, if it is asked most common route of spread in uterine TB, it's direct. Then uterine TB leads to Asherman syndrome or pyometra. The most common cause of pyometra is senile endometritis. The clinical feature would be infertility, followed by pain, followed by abnormal menses, right, which includes amenorrhea, more commonly than oligomenorrhea. In Asherman syndrome, amenorrhea is most common symptom, followed by hypomenorrhea. The most common presentation would be a normal pelvic examination, followed by tenderness. And adnexal mass is the least common presentation. Now, this is true for reproductive female, while in younger female, an adnexal mass will be the most common presentation. Right, remember reproductive age, normal pelvic exam, followed by tenderness, and in young or females or virgins, adnexal mass is the most common presentation of genital TB. Then diagnosis is made by doing a biopsy. We take two samples. One is sent for histopathological examination and the other is sent for AFP. We do a first day menstrual blood PCR because mycobacterium is in the superficial endometrial layer. For treatment, we'll give ATT for 6 months, and if anatomical distortion is present, then we undergo IVF. We don't undergo IVF, we ask the female to go for IVF. So this is genital TB. It is very important. Okay. Let's move ahead to uterine causes of infertility. First is submucosal fibroid. Second would be an endometrial polyp. Third, Asherman syndrome. Fourth, diethylstilbestrol use. And fifth, chronic endometritis, right? We will do ultrasound to look at the pathology, and we can uh, see Mullerian malformation here as well, right? For which investigation of choice will be 3D ultrasound and gold standard will be MRI. Cervical factor infertility, it is due to immunological cause like the presence of anti-sperm antibody which leads to immotile sperm. The investigation is post-coital test or Sims-Huner test. Right, it is just important for MCQ purpose. It is managed by intrauterine insemination. Right, we bypass the whole route for the sperm and directly place it inside the uterus. Intrauterine insemination. Semen needs to be processed, and it is important that the minimum sperm count should be 10 million per ml. That is, the sperm count should be more than or equal to 10 million per ml. This is a very important point. Next, it can be done for males who suffer from erectile dysfunction. Right. Third, it can be done if female suffers vaginismus. Fourth, cervical factor infertility. We just read about it. And fifth cause is minimal to mild endometriosis. Right. Here we give clomiphene citrate followed by intrauterine insemination. And for unexplained infertility as well, we give clomiphene citrate plus intrauterine insemination, and we do it for 3 cycles. Remember the point that the minimum sperm count is 10 million per ml. Now let us talk about the male factors, but before that let us look at the semen analysis. So when we perform semen analysis, we advise the patient, the male partner, to undergo abstinence for at least 2 days, and the range is 2 to 7 days. He should not masturbate, and ideally the samples should be given in the lab, but if the sample is given at home, it should reach within 1 hour. Right. Then the liquefaction time for semen is 30 minutes, and it is only studied after it has liquefied, while the lifespan of sperm is 72 hours, and spermiogenesis takes place approx 74 days. Right, these are some numerical questions that can be asked in the examination. Talking about the WHO criteria, so WHO specifies the minimum number of everything, like, right, so the volume should be more than 1.5 ml. If it is less, it is called aspermia. The pH should be more than 7.2. The sperm count should be 39 million per ejaculate. The concentration is 15 million per ml, right? If it is less, it is called oligospermia, right? 10 to 15, less than 5, and absence is azoospermia. Then motility, it should be 40%, while progressive motility should be 32%. Any abnormal motility is called as asthenospermia, and in Carter syndrome there is asthenospermia due to ciliary dyskinesia. Right. Then morphology. So 4% of sperm should have normal morphology, and it is a strict criteria. If there is abnormal morphology, it is called teratospermia. Then vitality should be 50%. In cystic fibrosis, due to the bilateral absence of vas deferens, there is azoospermia, and also it is seen in Klinefelter syndrome. The most important criteria in semen analysis is morphology, followed by motility, followed by concentration of the sperm. How do we manage oligospermia? For mild oligospermia, we have already read IUI can be done. If it is severe or azoospermia is present, then the next step is reconfirm the diagnosis, right? And the minimum time interval between taking two samples is 1 week. After the diagnosis is confirmed, like we do hormonal tests like LH, FSH, and testosterone levels. So let us see. This is the hypothalamus, pituitary, and the testes. Like in female HPO axis, the hypothalamus secretes GnRH, which stimulates pituitary to secrete FSH and LH, which in turn stimulates the testes to secrete testosterone. Then the outflow tract for semen. In testes, sperms are produced, which travel via the epididymis to the vas deferens. Then ejaculatory duct is present, which brings the secretion of seminal vesicle. Correction, ejaculatory duct is formed by the union of seminal vesicle duct with the vas deferens. Finally, seminal vesicle contributes to sperm volume and fructose content of the sperm and lead to the formation of semen. Now, if LH, FSH, and testosterone, they're all normal, it means that there is obstructive azoospermia. So, we check for then serum fructose levels. If fructose is present, it means that the obstruction is above ejaculatory duct or at the level of vas deferens, for which the investigation would be a scrotal ultrasound. Right, here the volume of the semen would be normal and scrotal ultrasound would be done. For example, in cystic fibrosis, where vas deferens is absent. If fructose is not seen in the semen, this means that the level is below ejaculatory duct, below seminal vesicles, that is at the level of ejaculatory duct. So here the volume would be decreased, there would be decreased sperm, and fructose will not be present. For all these cases, for when fructose is absent, that is at the level of ejaculatory duct, we do a transrectal ultrasound. Right. In these cases, since there is obstruction, the seminal vesicle will be dilated as they are unable to pour their secretions, and there is a thumb rule that wherever there is dilation, wherever there is obstruction, structures proximal to it will be dilated. Now, if on TRUS, there is no dilatation of seminal vesicles or no signs of obstruction, this implies that there is retrograde ejaculation, right? And to confirm, we will do a post ejaculate urine analysis. So, how do we manage obstructive azoospermia? By doing resection and anastomosis. Then coming to the abnormal levels of hormones, when LH-FSH is increased but testosterone is decreased, this means that there is obstruction at the level of testes. This is called hypogonadic, primary hypogonadism. And if all are decreased, it means that there is secondary hypogonadism. Right, and the problem would be at the level of hypothalamus or pituitary. So, the treatment of oligospermia, right? So we know that if the count is more than 10 million, we will do intrauterine insemination. Now, if the count is less than 5, that is severe oligospermia, we advise the patient if the sperm count is between 5 to 10, we advise the patient to undergo IVF, while in severe oligomenorrhea, the best treatment is ICSI, that is intracytoplasmic injection of sperm, while in azoospermia, we extract the sperm by TESI followed by ICSI. For obstructive, we already studied. The treatment is resection and anastomosis. And if it is not responsive to that, then we advise ICSI to the patient. Right, TC is surgical, taking out sperm from the testes surgically. So let us study the indications for IVF. Right, enumerate them in one place. First is tubal factor infertility. Second is premature ovarian failure. Third is Mullerian agenesis. Fourth is endometriosis. Fifth is Asherman syndrome. Sixth is when the sperm count is between 5 to 10 million per ml. Right, in Mullerian agenesis, surrogacy will also be advised along with IVF, and premature ovarian failure, donor egg is also needed. Right, so with this we complete our important topics in gynecology. One topic is left that is very important, pap smear, which I plan to do in one of the special sessions. So do wait for that video, and it will be a very high yield question because pap smear is a very important topic. Hope you liked Gynae. Stay tuned for OBS. Bye bye. Happy learning.